Austin. Dr. Nick Freidberg is a board-certified urologist from Urology Austin. He completed his medical degree at UT Health San Antonio and completed his residency at George Washington University in Washington, D.C. Sorry about that. After completing his robotic surgery fellowship at the University of Kentucky in Lexington, he returned to Austin in October 2022. He works with each patient at Urology Austin to ensure an accurate diagnosis and effective treatment, and has a strong passion in treating patients with prostate cancer and other urologic conditions. His biggest goal is to help men and women move past their urology issues to feel their best. We do have a lot of great content to cover tonight, so Dr. Freidberg, I'm going to turn it over to you to get us started.
Thank you. Thank you so much. Good evening, everybody. Thank you for joining us. The agenda tonight is just kind of a prostate cancer overview, and then we'll discuss some different treatment options, radiation therapy, and the space-to-air hydrogel, and then kind of next steps where you can go if you have more questions or want more information based on what we talked through this evening. All right, so first we'll start off with, what is the prostate? Well, it's a walnut-sized gland that sits at the base of the bladder in males, adjacent to the rectum, just anterior, as we say in medicine. It's part of the male reproductive and urinary systems. It surrounds the urethra, kind of like a donut, and it supplies the fluid that transports sperm during ejaculation. So we have, enlarged prostates versus prostate cancer, and oftentimes this can be a little bit confusing. So there's a term, benign prostatic hyperplasia, or BPH, which is commonly known as an enlarged prostate. And as men age, the prostate can continue to grow. And since it surrounds the urethra kind of like a donut, it can grow inward and impinge upon the urethra, cause bothersome urinary symptoms. And the association here is that BPH is not cancer, it's benign, but it may coexist with cancer. Having a large prostate does not put you at higher risk for developing cancer, and they can also cause some overlapping symptoms, including weak urinary flow, difficult starting or stopping urination, and then also can increase the PSA level. So the normal prostate gland creates or generates PSA, which is an antigen that's found in the blood. And so the larger the prostate that you have, the more PSA you're going to produce. However, prostate cancer cells also produce PSA, and they produce PSA at a higher rate than benign cells, and that's how we utilize it as a tool for screening, which we'll talk about. So prostate cancer is the most common cancer among men after skin cancer. However, the 5-year survival rates are 98%, and we have a lot of excellent treatment options for it. So here's some statistics for us. This is 2022 data, prostate cancer in the United States. About 270,000 new cases are documented each year, about 34,500 deaths from prostate cancer each year. And then the 5-year survival rate for localized prostate cancer is greater than 99%. So really some excellent results from localized prostate cancer. And then the 5-year relative survival rate for all stages combined is 98%. So all in all, about 1 in 8 men will be diagnosed with prostate cancer during their lifetime. And so it's one of the reasons I'm a big proponent of PSA screening and early identification, because you can see that if it's found early, we have really excellent treatment options and really good outcomes. Risk factors for prostate cancer. Age is certainly a risk factor. The chances of having prostate cancer after age 50 increases fairly significantly. Over half of the prostate cancer cases are diagnosed in men that are over the age of 65. Genetics definitely play a role as well. However, more prostate cancer is diagnosed in men without a significant family history. Although having a father or brother or first degree, male relative with a history of prostate cancer carries more than double risk of having a prostate cancer later in your life. Race and ethnicity also play a role for not so well-defined reasons. We know that Black men are at close to 2 times more likely to be diagnosed with prostate cancer. And then Latino and Hispanic men are 21% less likely to receive treatment. And this, I think, speaks a little bit to, some disparities in health equity. Behaviors and lifestyle, there's some studies that suggest that chemical exposures, prostatitis, and sexually transmitted infections may also increase the risk of prostate cancer. So those are the big areas of prostate cancer risk, and we'll see a little bit later how those play a role into our decision making for screening. Early detection, like I was talking about earlier, with the greater than 99% 5-year survival when prostate cancer is diagnosed in a localized stage, meaning it's confined within the prostate, it hasn't spread to the lymph nodes or the bones. So early detection is key. Most prostate cancers are found as a result of screening, and we recommend that males start talking to their doctors about screening at age 50 for the average risk male. That means you have no significant family history or any of the other risk factors that were discussed on the previous slide. For age 45, we recommend screening for people who are at higher risk of developing prostate cancer. So this is Black men or men with a first-degree relative who have been diagnosed. And then we recommend even earlier screening at age 40 for men who have an even higher risk of prostate cancer. So this is going to be in men who have multiple relatives, so a very strong family history, or potentially a family member who had a very aggressive course of disease. Screening for prostate cancer. So screening is basically a way to detect a disease in a state before you develop symptoms. And so with prostate cancer, really, men don't develop symptoms until later stage prostate cancer. And so that's why it's pretty imperative that we have screening and early detection in order to be able to treat these cancers. The 2 most common ways to screen, we have a PSA blood test. It's a simple blood test we do in the office. It tests for the PSA content in the blood. And if that number is elevated, then that raises suspicion of prostate cancer. And we also perform digital rectal examinations. And so these are the finger exam that is oftentimes dreaded, but also very important for diagnosing prostate cancer. If either of these results from these tests are abnormal, then we may recommend further testing. And this may be in the form of MRI of the prostate or a transrectal ultrasound, which are both imaging tests that look for areas of abnormalities within the prostate. And we also have now the ability to do genetic testing. So we can do testing to see if the patient is at elevated risk, which would be a impetus to pursue a biopsy. Non-screen detected prostate cancer. So this is prostate cancer where patients may be diagnosed without screening during the workup of symptoms. So symptoms may include pain, urinary blockage, bleeding, or other potential symptoms. A prostate biopsy is the only way to confirm the presence and severity of prostate cancer. So we talked about the MRI of the prostate and transrectal ultrasound and genetic testing and the PSA value and the digital rectal exam. All of these are screening tests that raise our suspicion that prostate cancer may be present. A biopsy is a procedure in which we use an ultrasound to guide a needle that takes small samples of the prostate. These prostate samples are then submitted to a pathologist who looks at the samples under a microscope and determines whether or not prostate cancer is present. And then the pathologist assigns a grade to the prostate cancer cells that are given to him after the biopsy. And grading in non-metastatic disease, you have the TNM staging, which is the common cancer staging measuring the extent of the tumor. And then you also have something called the Gleason score, which is something we will commonly refer to when discussing a diagnosis of prostate cancer. Other factors that can determine the severity and the treatment recommendations are things like PSA testing, imaging. So this may be the ultrasound imaging or the MRI imaging. There's also a variety of different advanced imaging techniques like PET scans that we can do to determine whether the cancer is contained within the prostate or has spread elsewhere. Clinical exam results, genomic testing. So there's a lot of, we talked about genetic testing, which is kind of in the screening arena of things. But once we have a diagnosis of prostate cancer, we can actually test those prostate cancer cells to determine the aggressiveness and extent of disease. We also look at the volume of the tumor. So in a standard prostate biopsy, there's typically 12 different samples that are taken from the prostate, so 12 biopsies. And the pathologist, when defining whether or not there's prostate cancer in the specimens that we send him, also will look at the extent of involvement of the cancer. So the percent of each of the 12 cores that's involved with cancer, and then how many of the 12 cores are involved. And then there's also additional risk assessment models that have been generated by prior data. And these are all different tools that we can use to guide treatment decisions on one, whether or not we need to treat the prostate cancer, and two, what the best modality of treatment would be. So TNM cancer staging. So the T and the M and M, the T is for the extent of the tumor. The N is for nodes, or if the cancer has spread to the lymph nodes. And then the M is whether or not there's metastasis. The staging is most common staging system in the world. It's used for many, many, many different cancers, including prostate cancer. But in addition to the TNM staging system for prostate cancer, we also use what's called the Gleason grading system. And so a little bit more about the Gleason grade or the Gleason score. So prostate cancer is, at least in our practice, every single diagnosis is given a Gleason score, which assesses abnormal cell growth in the tumor. And so what happens is the pathologist has his specimen, and under the microscope, he assigns each core or each positive prostate cancer sample with a Gleason score. And this consists of two numbers. So you have your first number and your second number. The first number is the most predominant cell type that the pathologist sees in the sample. And then that is followed by the second number where there's a background of cancer cells that are seen in the sample. And these two numbers are added together to give you a Gleason score. So we also risk stratify the prostate cancer into low or very low, intermediate, and then high or very high. So a Gleason score of 6 or less is low to very low. Grade 7 is intermediate. Grade 8 to 10 is high to very high. So this is used along with the PSA level and potentially the genomic testing and the imaging, and all of this information is kind of synthesized to generate a treatment plan that is fairly individualized and has data supporting the best outcomes. So now that we're in the stage of treatment, we know that there are some prostate cancers that we have diagnosed that we don't necessarily need to treat. And this would typically fall in the very low or low risk category. And so in those circumstances, we can do something called active surveillance. Active surveillance usually consists of closely following the PSA values and potentially repeating imaging in the form of an MRI or repeating the biopsy at certain intervals. And we have a lot of data to support that this is a safe method for the carefully selected patient. With the understanding that the circumstances may change and we may have to move to treatment at some point. Removal of the prostate is also a treatment option for localized prostate cancer. This is done most predominantly using a robotic assistance, and so this is something I commonly do. It typically requires a one-night stay in the hospital and is a potential treatment option for localized disease of the prostate. And then we also have radiation therapy, which is another excellent treatment for not only localized, but sometimes cancer that has spread to the lymph nodes or has other involvement in other organs. So these are the three main treatments I would say as far as the most common. And then there's a number of other treatment modalities out there and research that's being conducted. So hormone therapy is often used in combination with either surgery or radiation. Cryotherapy is an option, albeit there's some unfavorable risks associated with that. And so I tend to steer my patients away from that a little bit. Immunotherapy is a newer technology with emerging data and may be beneficial in scenarios of prostate cancer. Chemotherapy is typically reserved for widespread or more aggressive prostate cancer. HIFU is high intensity focused ultrasound, and that is a treatment modality that kind of ablates the prostate tissue without having to remove the prostate gland. Emerging data on that as well. And then we also have targeted therapies. So there's a little into the weeds on that one, but yeah, so we'll move forward. But if you have questions about targeted therapy, I'm happy to answer them. So active surveillance, I know I talked a little bit about it on the last slide. It's monitoring the cancer and the symptoms very closely. So PSA tests very routinely, doing repeat rectal exams to make sure there's no change in the exam there. And then regular imaging in the form of MRI and biopsies. This is not an ideal option for any fast-growing cancer or tumor that's metastasized. Like I said, this is typically reserved for the very low or the low risk prostate cancer diagnoses. Potential side effects, it says none known. I would say the the risk of doing active surveillance is having the cancer spread beyond the prostate during the time period where we have decided not to treat you. There's a lot of data that suggests that this is extraordinarily uncommon. And so it's a very, I tell my patients that it's a safe option as long as we maintain the follow-up schedule. It's a safe and effective option, and it can delay treatment, which comes with potential side effects. So, yeah. And then surgery, we also discussed the radical prostatectomy. Here it has the open radical prostatectomy, which is an option still many perform today, although more commonly these days are the robotic laparoscopic radical prostatectomy. And this is done with a few puncture wounds in the abdomen and using the robot. Well, the surgeon controls the robot to a little bit more carefully dissect out the prostate gland. And the robotic approach is associated with less blood loss and a quicker time to full recovery. Potential side effects of surgical treatment, urinary incontinence. So this is, I tell patients that this is a common side effect of this procedure and almost ubiquitous. Urinary incontinence is something that has the ability to recover postoperatively, but certainly for a period of about 3 to 9 months after surgery, I expect most patients to have some leakage of the urine. Sexual dysfunction, similarly, for several months after the surgery, you will have impotence or the inability to have an erection. And this also has a good chance of recovery if we're able to spare the nerves that generate erections. However, it's likely that you will have a decrease in your sexual function than you had prior to surgery. And then you also have the loss of fertility. So this is infrequently a concern in prostate cancer because the majority of men are beyond wanting to start families, or 50, 60, 70-year-old men. And so typically that's not a concern, but it's certainly an outcome of the procedure. The vas deferens are severed on both sides, and so there's no ability to reproduce after the procedure. Risks are much like those of any major surgery. You have the risk of pain from the procedure itself. You have a bleeding risk, although it's quite small during this procedure. You have risk of damaging any of the structures that we're working around, and then the risks related to anesthesia and recovery. It does require general anesthesia, so certain patients who have medical comorbidities that would preclude them from undergoing general anesthesia may want to look at radiation as a treatment option. It requires an overnight stay in the hospital, and it is an invasive approach, as we discussed. And then that brings us to radiation treatment. So what is it? It's high energy rays or particles that actually kill the cancer cells. External beam radiation therapy is delivered by a machine on the outside of the body, so it's non-invasive. There's no general anesthesia required, no hospital stay. Treatments are generally outpatient. They can take only a few minutes and are typically painless. The potential side effects are similar to those from the radical prostatectomy, and with the addition of bowel dysfunction. And what I often tell patients is surgery, you take the hit up front, and all of the side effects are going to be present basically immediately after surgery. And they have the ability to recover function there. And then with radiation, you have kind of more unknown, and many men do great with radiation therapy and have minimal side effects down the line. However, there are a subset, a small minority of patients that have progressive bothersome symptoms that can be very difficult to treat. And so that it's kind of a risk-benefit analysis for deciding treatment, and definitely needs a thorough discussion on an individualized basis. So another form of radiation therapy is brachytherapy. It uses high energy rays or particles to kill cancer cells. However, the radiation oncologist actually implants radiation seeds into the prostate, and it's generally used in men with lower grade prostate cancer. It's not as commonly available as the external beam radiation treatment, and is invasive. Does it require overnight stay in the hospital? I don't know about that, potentially. And then does require general anesthesia. Similar side effects. One side effect I would potentially add for this one is there's a little bit higher rate of stricture or scar tissue building up within the urethra. And so I typically, when choosing the modality of treatment, I typically will have the radiation oncologist decide between brachytherapy or external beam radiation treatment, and leave that discussion up to them. And we listed out a little bit of the other treatment options. Cryotherapy uses cold gases that freeze and kill the cancer cells under general anesthesia. Hormone therapy aims to reduce the levels of the male hormones in the body to slow cancer growth. Chemotherapy are anti-cancer drugs that are typically delivered via the IV or taken orally to reach the cancer cells through the bloodstream. Typically when you have spread of the prostate cancer beyond the prostate. Immunotherapy similarly uses drugs to stimulate the immune system to target and destroy cancerous cells. However, this is also kind of in development stages, and has not been shown to cure prostate cancer. So is not a first-line treatment for localized prostate cancer. Targeted therapy uses drugs to identify and attack the way a cancer cell grows to limit their growth and repairs itself or interacts with other cells. So there's several stages in kind of the cell cycle that targeted therapy works to reduce the proliferation of cancer cells. And HIFU is a high intensity focused ultrasound. It uses a probe that's inserted in the rectum to deliver high intensity treatment to targeted areas of the prostate. And this treatment modality is used in very select cases of kind of a known isolated area of disease within the prostate, and it has to be lower to intermediate risk prostate cancer. All right, so that brings us to radiation therapy and the use of the SpaceOAR hydrogel. So first, we'll talk a little bit about understanding the radiation side effects. So the prostate's in proximity to several surrounding organs. So you run into the possible side effects of urinary, sexual, and bowel dysfunction. The rectum is considered an organ at risk due to the proximity of the rectum on the prostate. You can see in the image there, the prostate in kind of the orangish red. And then we have the rectum posteriorly that's marked there. And so they're in very close proximity and are at potential risk of radiation damage, collateral damage from the radiation treatment during the course of treatment. Rectal toxicity side effects can include diarrhea, pain, bleeding, fecal frequency or fecal urgency, and it can be a really troublesome and difficult to treat outcome. And so that's why we commonly recommend the use of SpaceOAR. And so rectal spacing for radiation treatment is also known as SpaceOAR. Basically uses a hydrogel rectal spacer to reduce late gastrointestinal toxicity and lower the odds of developing any toxicities. So in one study on radiation effects to the digestive system, 551 patients underwent the radiation therapy for prostate cancer. About half of those received SpaceOAR 269 as a pre-treatment. And you can see on the image to the right here, the patients in blue are the SpaceOAR patients, and the patients in gray are the patients who did not receive SpaceOAR. And there's a very significant reduction in rectal toxicity that's associated with the symptoms that we discuss. So does it make a difference? Yes, it makes a big difference. SpaceOAR is an absorbable hydrogel that temporarily creates space between the prostate and rectum. It's designed to reduce the radiation dose to the rectum to help minimize the side effects for surgery. So in the schematic there, you have the prostate, which sits kind of right on top of the rectum, and that SpaceOAR hydrogel is injected between the prostate and the rectum to spare the rectum from inadvertent radiation damage. It creates about 1.3 centimeters of space between the rectum and the prostate. It's a soft gel made of mostly water and polyethylene glycol, which is commonly used in medical implants. It's a brief outpatient procedure, use local or can do it with general anesthesia. It stays in place for about 3 months, and after approximately 6 months, it's naturally reabsorbed and leaves the body through the urine. So more space can make for a better quality of life. Fewer bowel complications, certainly. 3 years following treatment, patients experience 75% less grade 1 rectal toxicity. So these are things like fecal urgency, loose stools, or fecal frequency. They also experience fewer urinary complications. So it reduced the likelihood of decline in urinary quality of life by 60%. And then also fewer sexual complications. So 67% of SpaceOAR patients who were potent at baseline had erections sufficient for sexual activity at 3 years. So that's pretty impressive. And especially when you're considering surgical treatment versus radiation, I mean, I think this is a significant advantage. The combined use of SpaceOAR with external beam radiation treatment is an excellent consideration. More than 500 cancer centers around the world purchase SpaceOAR hydrogel with 220,000 patients to date and growing. This is Dr. Gray. He's a practitioner and patient, and he's gonna, it's a quick 2-minute video about the SpaceOAR hydrogel.
My own journey in prostate cancer personally started about 1.5 years ago. What I feared about being diagnosed was just knowing that I was going to have to go through the process. I had the same common fears that any patient would have. What are going to be the side effects in me personally? I've been a radiation oncologist for over 30 years now. As a radiation oncologist, I get to see virtually the entire spectrum of cancer patients. I was in a position where I was in one of the earlier stages of the disease, so I could make a choice. I had essentially surgery as a choice, and I had radiation as a choice. I've been treating prostate cancer for a long time, and one of the issues we have using radiation in any mechanism is that there are sensitive organs nearby. Primarily, we worry about the bladder and the rectum. The problem is the prostate and the rectum live right next to each other. So how do you actually give radiation to one and not to the other? So Treating prostate cancer is easier if you can keep the rectum a little bit out of the way. When it came to me personally, it was more, you're not going to treat me unless I have spacer applied for me. This new mechanism of inserting a hydrogel between the prostate and the rectum in a very minimally invasive mechanism, very minimally invasive manner that allows you to keep the prostate and the rectum just a little bit separate from each other, it really gives you an advantage. It was tested in clinical trials several years ago and proven to reduce the likelihood that the rectum would be irritated as a result of treating the very nearby prostate. So when I learned about it, it was to me, a no-brainer. This is going to be a great improvement in how we can do radiation treatment. And I started offering it to my patients. So it's one of those kind of win-wins that we come across in medicine every once in a while that allows us to improve our outcomes without having to pay a large price in how much is this going to cost, or are there downsides to this? Like most of my patients, once the spacer was applied to me, I couldn't tell a difference. I didn't have any difference in my bowel function or my urinary function. So it helped confirm for me, yeah, this actually doesn't hurt that much. And yeah, you walk out of here almost like it wasn't done. That's very gratifying. But knowing then and seeing my own CT scan, and I know that we're going to be able to execute a plan to treat my prostate without including my rectum in part of that planning, it really hit home. This was not just one of my patients. This was me. This was my pelvis on that screen, and I could see that I was going to be able to treat my prostate more effectively without involving the rectum. So it was, kind of an eye-opening experience.
All right. So yeah, if a radiation oncologist is blown away by it, then I'm a believer too. And in summarization, radiation therapy can be extremely effective in treating prostate cancer, but as with any procedure, there's potential side effects. The prostate is right next to the rectum. Due to the proximity, prostate radiation therapy can unintentionally cause harm to the rectum, which can lead to issues with bowel function that can be difficult to manage or treat. Spacer hydrogel is designed to temporarily create space between the prostate and the rectum, reducing the radiation dose delivered to the rectum and thereby lessening the damage or the potential for damage to the rectum. So a little bit about next steps. I think, knowing your risk level. So making sure that, your doctor has done the due diligence in establishing a diagnosis and a stage and a risk stratification for you. Knowing your Gleason score and your PSA is helpful. I think if you have not been diagnosed with prostate cancer, then certainly I'm a big proponent in talking to your physician about screening and the risks and benefits of screening for prostate cancer. If you have friends or relatives, I think talking to them about talking to their doctor about screening is also helpful. Learn more about the treatment options. This is a little bit of a brief overview, but I definitely encourage you to do your research on the different treatment modalities. Some really good resources, American Cancer Society or cancer.org. Zero Prostate is zerocancer.org. The Prostate Health Education Network, prostatehealthed.org. Or if you have questions specifically about SpaceOR, you can text SpaceOR to 73771. You can speak to a patient education coordinator, or you can visit spaceor.com. And then the references are here, and I believe this is going to be, this recording will be sent out. Is that right, Abraham?
Yeah, I believe Urology Awesome actually provided or posted on the website.
Okay, so you guys are welcome to look into the references there. I'm happy to take any questions at this point.